Hello everyone. So this is part 2 video. The first video was normal labor and this will be about abnormal labor. Hopefully this will be a shorter video because this might not be as important for us right now. We're just gonna learn a bit about it. Anyways, so abnormal labor, we before we talk about it, first of all, we talked about the stages of labor and the normal type of labor. You should watch the first video to understand it. So if we just go quickly about it, there is stage one has latent and active phase, and then we have stage two, which is delivery of the baby, and stage three, which is delivery of placenta. So at this stage one, we have latent phase. At the end of the latent phase, there will be 6 centimeter dilation of the cervix. In the active stage, there will be from 6 to 10 centimeters. And the stage two, we said the baby will be delivered, and this is the placenta. Anyways, the pathologies. Okay, so if we talk about the abnormalities, where's abnormalities here? Abnormal labor. So the latent phase, the abnormality is a prolonged latent phase. Okay, the active phase, the abnormality is an arrested active phase. And the second stage again is prolonged, and then the third stage again is a prolongation. That's the abnormality. So we have a little case here just telling us, oh, then there's like the latent phase. There's like a 29-year-old multi-gravida at 40 weeks term. Gestation is being observed in the maternity unit. She states she has been having regular uterine contractions for 24 hours, but cervical dilatation or dilation remains 1 to 2 centimeters. Okay, but the baby is okay. Okay, so this is here. It talks about some stuff. I wanna talk about it on the table we have. So this is the pathology, the prolonged latent phase here. Okay, so we said latent phase in primipara takes less than 20 hours, and in multipara takes less than 14 hours to reach the 6 centimeter dilatation. So if we have in 14 hours no cervical changes, no making like from 2 centimeters doesn't become even 5 centimeters or something, it just stays at 2 centimeters. This is one of the triad for the prolonged latent phase. And then we have cervix dilated 2 centimeters, it's not getting to 6 centimeters. And we also have regular uterine contractions. So we have contractions, but it's for some reason it's not working. Okay, so what are the causes? The causes are hypo or hypertonic contraction. And in judicious, it's just like a word like that. It's two causes. Let's see. Injudicious, yes, analgesia, which means careless analgesia. It's bad, it's not a good analgesia, might cause prolongation of the latent phase. The other causes is hypertonic or hypotonic contractions. The hypotonic contractions mean what? Mean inadequate frequency, duration, or intensity. The hypertonic means high intensity, okay, high intensity, but inadequate duration or frequency. And the management here, what's the management? Rest with narcotics, oxytocin, or amniotomy, okay? Uh, Narcotics, oxytocin, and amniotomy. If we can make a little mnemonic for this, NOA, you can do something with this maybe. NOAA, yes. So the active stage, we have arrest of active phase. Let's just see if we can just study it here. So arrest of active phase, here is like the how you know it's an arrest. No cervical changes despite more than 6 hours of more or equal to 4 hours of active uterine activity. So we reached 6 centimeters dilation. Okay, we finished latent phase, and then we see it's been 4 hours or more uh, with active uterine activity, but there's no cervical changes. The 6 is not becoming a 10. Or we also gave oxytocin and it's been even 6 hours and it's still there is no change. Okay, so without oxytocin, more than 4 hours and there is still no change, or with oxytocin, more than 6 hours we wait and there is no change in the cervix dilation. So that's a arrest of active phase. The causes are either the passenger, the pelvis, or the power. You probably know what this means. I'm gonna check it in a bit. Um, Actually, I'll check it right now. So this is the case for the active phase. You're just gonna read it. It's the same as we just talked about. The cause is a problem with the passenger. Maybe the fetus is an elephant. It's very big. Abnormalities with the pelvis. The pelvis is small and there's a problem with it. Maybe the shape abnormality with power, dysfunctional or inadequate uterine contractions. So what's the management? It says here contractions should be occurring every 2 to 3 minutes, at least 50 to 60 seconds, with 50 millimeter mercury intensity. If contractions are hypotonic, we just said what hypotonic is. IV oxytocin is administered. If it's hypertonic, give morphine. And if contractions are adequate, okay, so it's not hypotonic and hypertonic, we do emergency cesarean section. So let's go back. Now let's not forget, we're just studying it once. We want to remember. It's right here. If hypotonic, oxytocin. If hypertonic, morphine. And if it's adequate, there's no hypertonicity or hypotonicity, we do cesarean section. So right now we study these two, the stage 1, latent and active phase. We said the latent phase, how is it a pathology? If there is regular contractions, there is contractions, but there is one problem. We have contractions, yet the cervix is not dilating more than 2 centimeters, and it's been 14 hours. Okay, it's not coming here. So that's a prolonged latent phase. We said the causes are hypo or hypertonic contractions or injudicious analgesia. Okay, one of these two. And the management is NOA, so narcotics, oxytocin, and amniotomy. Arrest of active phase, no cervical changes despite 6 hours with oxytocin or more than 4 hours of active uterine activity, so there's no change from this to this. The problem is either passenger pelvis or power. If it's hypotonic, we give oxytocin. If it's hypertonic, we give morphine. This is just the hypertonic and hypertonic is in both of them. If adequate, we do cesarean section. Okay, now we come to these two. So stage 2, okay, so stage 2, we said it's the stage where the baby is expelled. So it's the descent of the baby. It takes less than 3 hours in primipara and less than 2 hours in, or primigravida or whatever you call it, and less than 2 hours in multipara. So how do we prolong this? We make these the opposite way. Okay, so in a nullipara, here it says more than 3 hours without epidural anesthesia. So it's been 3 hours. We haven't given anesthesia. It's been 3 hours and the baby is still not out. In multipara, it's been 2 hours and the baby is still not out. And if we gave the person epidural anesthesia, we also count plus an hour to these times. Okay. So it doesn't really talk about the cause in this textbook, but what is the management? The oxytocin. Okay, we give oxytocin to make the contractions more, and assess whether the face is engaged or not, either cesarean section or forceps. Okay, so we do one of these. Anyways, the stage 3, okay, it's delivery of placenta, which takes 30 minutes. So how do we say that there's a problem here if it's been more than 30 minutes and there's still no placenta out? Okay, so what is the causes? Inadequate contractions even with oxytocin. So here it says maybe the cause is because of right here. Yes. So think of abnormal. It says maybe due to inadequate uterine contraction if placenta does not separate in spite of IV oxytocin's simulation of my. Okay. Anyways, it says think of abnormal placental. So even if you give IV oxytocin and there is still no coming out of the placenta, we can think of placenta accreta, placenta increta, and placenta percreta, which is what? Which is basically just the invasion of the placenta too deeply into the uteral wall. So this is accreta, okay. As we see, there's a bit more invasion than the normal. This is increta, that's more in the muscles, the myometrium, and percreta, which is like very deep, it's even crossing a bit. Okay, here it is on the baby. So, so there's just normal removal. What is this? I don't know what's written here. Or rarely hysterotomy. First management, right here, may require manual placenta removal, sorry, not normal, manual removal, or rarely even hysterectomy. So we are done with our table. You can take a little screenshot of everything here. Okay, so this is the normal stages, this is the pathologies, this is the cause of each one under it, and this is the management of each one. So now come to obstetric complications during labor. We have prolapsed umbilical cord, we have shoulder dystocia, and here we have obstetric lacerations. Okay, so what's prolapsed umbilical cord? It's when the umbilical cord gets into a place it shouldn't be. Okay, so this is a case, it's talking about a blah 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 patient is like doing something, is getting a baby. During the examination, the patient's bag of water suddenly ruptures. Oh no. and a loop of umbilical cord protrudes through the cervix between the fetal extremities. Okay, so this is a problem. This is umbilical prolapse umbilical cord. An umbilical cord prolapse is an obstetric emergency because if the cord gets compressed, the fetus doesn't get oxygen and might cause death. So what is the risk factor? The risk factor is rupture of the membrane, okay? Especially, okay, with the presenting fetal part not applied firmly to the cervix. So uh, if this head part is not firmly applied right here, okay, let's say it's here, so there is more space for the umbilical cord to come here, especially when the membrane ruptures, it will instantly go between here. So we have types, okay. We have occult type. The cord has not come through the cervix, but is being compressed between the fetal head and the uterine wall. So this is the occult, okay? Is the cord is not anywhere near the cervix. It's not about the cervix here. It's about the fetal head compressing this guy against the wall, okay? Against the wall, and will cause a problem. And then we have a partial and complete, or an incomplete and a complete. The incomplete, the cord is between the head and the dilated cervical os, but has not protruded into the vagina. So this is the cord presentation, it's called. It's right here, you see. It's with the cervix, but it's not come through. This is the incomplete, and this is the complete. Sorry, this is the complete where it has fully come out. Okay. So, what's the management? Do not hold the cord or try to push it back. Place the patient in knee chest position. Elevate the presenting part. Avoid palpating the cord, and perform immediate cesarean delivery. Anyways, so shoulder dystocia. Again, there's a person here having a baby. The shoulders are stuck and they're not coming out. Okay, so uh, it says what here? The diagnosis is made when delivery of the fetal shoulders is delayed after delivery of the head. It's usually associated with fetal shoulders in the anterior posterior position. So it's like this. It's anterior posterior. And this is causing a problem because it's too much and might go behind the pubic symphysis. Okay, so the anterior shoulder impacted behind the pubic symphysis. It occurs in blah blah blah. Anyways, what are the risk factors? So we have a little cute mnemonic here. It says from the nutrients. What does he mean by nutrients? From glucose, fat, and more time to eat. By glucose means the risk factor of maternal diabetes, and by fat means obesity and more time to eat post dates pregnancy. So it's after term, so the baby has more time to eat and is bigger inside the mother. Okay, obviously they're not eating, but they're growing bigger, which are associated with fetal macrosomia. Even though the blah blah, this you can read it yourself. The management, I will not be managing this case, so good luck. You can read this yourself. Uh, we have then obstetric lacerations. Perineal lacerations are classified by extent of tissue disruption between the vaginal introitus and the anus. So let's just say this is the vagina, and who should we put in between here? Let's put the perineal body, and then let's put the anus here. Okay, okay. Anyways, so first degree involves only the vaginal mucosa. Such a repair is often not needed. So the first degree is right here. Okay. Second degree involve the vagina and the muscles of the perineal body, but do not involve the anal sphincter. Such hearing is necessary. So let's go to the second stage. Yes, let's hit the perineal body. Okay, now we've done our damage in the second degree. The third degree involves the vagina with the perineal body and the anal sphincter, but do not attack the rectal mucosa. Such hearing is necessary again to avoid anal continence. So let's come here and let's hit the sphincter right here and cause a problem right here. Okay, now we're in the third space. So here's 1, 2, 3. Now, where else could we cause a problem is if we come and attack the mucosa. Again, such hearing is needed. So that's the 4 stages. Episiotomy, we know what episiotomy it is. We do it to enlarge the vaginal opening and assist in childbirth. Now there's some false arguments, means these have been said, these words, but they are false. So it says episiotomy has less perineal pain, lies. More rapid return of sexual activity, again lies. Less urinary incontinence, more lies. And less pelvic prolapse. Anyways, what are the disadvantages of episiotomy? More perineal pain, okay. And then with lacerations, so essentially just this here. Then with lacerations, longer return to sexual activity. and more extensive. It's literally just like the false arguments, opposite. Possible indications is shoulder dystocia, we just said it, non reassuring fetal monitor tracing, forceps or vacuum extractor vaginal delivery, vaginal breech delivery, so the bottom of the baby is coming out first, and a narrow birth canal. And that's shortly it for the problems, obstetric complications during labor.